of healthcare engineering. Then I'll move into an overview of my internship, the key findings I focused on, and the insights I gleaned from this experience, followed by a summary and a look at future work in the area. If you have any questions, please hold on to them and I'll be happy to provide an answer at the end of my presentation. Also, one more thing to note before I start, I have referenced specific articles on some slides. For others, the information has been synthesized from multiple sources and from my personal experiences. These have been cited on the last two slides at the end of my presentation. So without further ado, let's get started with the introduction. With a growing shift towards patient centered care, many healthcare organizations are prioritizing patient satisfaction and loyalty as a strategy for sustainability and profitability. Research has revealed that a vital component of enhancing patient experience is engagement with healthcare professionals, particularly with physicians. This has led to a rising expectations from physicians to provide better service, timely care, and continued access within the society. This has led to a growing epidemic of provider burnout. Burnout in a professional setting is a reaction to prolonged stress, manifesting in the form of loss of enthusiasm for work, feelings of cynicism, and a low sense of personal accomplishment. Initially, burnout might coexist with empathy, satisfaction, and caring, but unrelieved work stress for months or even longer may result in emotional exhaustion and feeling helpless, trapped, or defeated. This can also cause depersonalized interactions when physicians start to treat patients indifferently or develop a negative attitude toward their colleagues or their profession. However, burnout should not be dismissed as an expected reaction to hard work. Several individual and organizational factors contribute to provider burden and workplace stress, which I'll be talking more about in a minute. It is definitely more common among physicians compared to other workers in the United States. Although the practice of medicine can be incredibly meaningful and personally fulfilling, it is also demanding and stressful. An online survey conducted by researchers at the Mayo Clinic found that nearly 50% of practicing physicians reported at least one symptom of burnout. Another study that evaluated the prevalence of burnout and satisfaction with work life balance showed that there was an 8% decline in physician satisfaction from 2011 to 2014, which just goes to show that this is a pervasive problem that appears to be getting worse. Burnout has profound implications on individual physicians, patients, and healthcare systems alike. Increased provider burden can contribute to the indiscriminate use of resources, further increasing the cost of care. In addition, clinical practices with unhappy and dissatisfied providers are likely to see higher rates of turnover. This can threaten patients' access to healthcare and their continuity of care. Burned out physicians may also suffer from impaired attention, memory, and executive function, contributing to an increased risk of medical errors, inappropriate prescribing practices, and lower levels of empathy. This can in turn result in reduced patient satisfaction, experience, and medication adherence, ultimately reducing health outcomes as a whole. The high prevalence of physician burnout suggests that its causes are systemic rather than specific to individual physicians' coping skills. A study conducted by the Agency for Healthcare Research and Quality found that work conditions such as time pressure, chaotic environments, low control over work pace, and unfavorable organizational culture were strongly associated with physicians' feelings of dissatisfaction, stress, burnout, and intent to leave the practice. More than half of the physicians in this study reported experiencing time pressures when conducting physical examinations, and a quarter of them felt that they had no control over their pace of work or schedule. Numerous studies have also found that practices that implemented electronic health records saw an increase in stress as the use of EHRs matured over time. And then there was a sharp decrease, but the stress did not return to baseline level. Additionally, fully mature EHR systems were associated with physician stress and burnout. This is a surprising discovery since the widespread adoption of EHRs was expected to transform the daily activities of providers for the better. This is definitely true, but only to an extent. With the advent of digital computerized versions of patients' paper charts, electronic health records have been instrumental in making information available instantly and in a secure manner. By reducing transcription costs, EHRs have helped medical practices become more efficient and cost effective. EHRs have also increased patient participation by creating an avenue for communication between providers and their patients. This has also allowed patients and providers to collaborate in informed decision making and adopt a more holistic and patient centric approach to care. As medical practices and technologies have advanced, the delivery of medical care has come to require teams of healthcare providers, including specialists, nurses, pharmacists, and other clinicians. EHR systems have decreased fragmentation within health systems and improved care coordination by integrating patient health information and allowing it to be instantly distributed to all those involved in the patient's care. There are numerous benefits to using EHRs for sure, but when research was conducted on providers' experiences, some unintended consequences of EHR use were found. In a 2011 survey, 87% of physicians cited the administrative and paperwork burden as the leading cause of work related stress. This included time consuming data entry, dictation, and clerical tasks such as completion of forms. Another survey conducted in 2013 found that EHR technology had an adverse effect on professional satisfaction, citing poor usability, lack of interoperability, and degradation of clinical documentation because of frustrations with template generated notes. Over three-quarters of physicians complained that EHRs interfered with patient care while increasing the time and effort needed to plan, review, order, and document the care provided. And another study conducted at a Veterans Affairs hospital found that primary care physicians spend nearly 50 minutes daily to respond to alerts, out of which nearly 80% of these alerts were non-emergent. So, despite the numerous benefits of electronic health records, there is widespread evidence to support their negative effect on provider satisfaction. To address these causes of provider burnout, the Wellbeing Program was launched as a collaboration between UNC Healthcare, UNC School of Medicine, and UNC physicians. This is a comprehensive, system wide approach to find innovative ways to improve both EPIC, the EHR interface used at UNC, and the flow of clinical practice. The goal is to meet the fourth arm of the quadruple aim. The quadruple aim, which was established by the Institute for Healthcare Improvement, is a compass to optimize health system performance. It includes enhancing patient experience, improving population health, and reducing costs, with the fourth arm being preventing burnout and improving work life. So, through this initiative, wellness was formally adopted as a crucial measure of performance by the UNC healthcare system. A pilot project with hospitalists was conducted as an initial study, with numerous improvements being implemented by the senior leadership. To build on the success of the initial hospitalist pilot, the program was then expanded to include critical provider groups at UNC Healthcare, which was the focus of my internship. This study was conducted at the University of North Carolina at Chapel Hill and constituted a smaller component of the overarching well-being program. We aim to identify and explore the causes and contributors of workplace stress and provider burden with a specific focus on technological barriers, including the use of electronic health records. The purpose of my project was to identify system breakdowns that contribute to provider burnout and propose solutions to overcome technological challenges that interfere with provider well being. Along with the well-being team, this study was conducted across two hospitals within UNC Healthcare in both inpatient and outpatient settings across two specialties, cardiology and oncology, for about 6 months. The study entailed conducting socio-technical assessments of the system by using contextual inquiry to explore burdens, breakdowns, and frustrations for physician specialists. Contextual inquiry is an essential component of contextual design, which is a customer centric approach at designing systems. In contrast with other analytical methods, contextual inquiry requires active participation from users at multiple steps throughout the process. This approach builds upon in depth field research that is then used to analyze uh, and iterate solutions to systemic problems. Contextual design in its true form involves three sequential steps. The first is immersion, where the research team participates in immersive experiences led by the user through field visits, followed by a discussion of insights with the team. Next, the team utilizes the collected data to devise product concepts and innovate. And third, the proposed design then goes through periodic validations and iterations by various stakeholders, including users, to arrive at a concrete solution. In this study, a modified version of the contextual inquiry was applied. The first step was immersion, where the research team shadowed providers in real world hospital settings. Next was interpretation, where the findings were discussed with the team to promote a shared understanding of the concept, followed by modeling of the data and the insights that were obtained from the first two phases. Since this research was conducted under the auspices of the provider's work environment, and oversight of an institutional review board was waived, but every effort was made to protect sensitive information and protect the confidentiality of the participants. I will now be going over each step of our modified contextual inquiry approach with some details. The data was collected over a period of 3 months through direct observation. 11 shadowing experiences were carried out by one or two members of the research team per session, where several oncology and cardiology providers were observed in inpatient and outpatient settings. Providers comprised of attending physicians as well as advanced practice providers or APPs, which included nurse practitioners and physician assistants. The goal of these immersive activities was to gain an understanding of healthcare providers' daily workflow and team dynamics, to identify any bottlenecks or breakdowns that were likely to contribute to stress. The data was recorded manually in a notebook, and it was later transcribed into a Microsoft Excel spreadsheet, as you can see here. The spreadsheet was password protected and only accessible by the research team. and all the observations were coded so as to remove any identifiable information specific to any provider. Next, interpretive sessions were conducted. At the end of every shadowing experience, the observations and particularly the significant breakdowns identified were discussed in a one on one interview with the provider being shadowed. During weekly team meetings, the findings and potential issues were discussed with the research team. For each session, one researcher served as the moderator, and usually this was the person who conducted the interview or the shadowing experience. And this person acted as the moderator who reported out the observations and the experience and also facilitated the discussion. Another team member developed a preliminary version of a roles and relationships model, which I'll talk more about in a minute. And another member recorded the breakdowns and or findings that required further clarification. So in this way, every member of the research team had an active role to play in analyzing the observational data and contributing to a shared representation of the provider's workplace experience. Then we moved into organizing the data into models. Subsequent meetings with the team delved into further honing the roles and relationships model, followed by the development of an affinity model. The roles and relationship model, as you can see on your left, it was chosen to represent the multidisciplinary nature of healthcare teams. It was used to indicate positive as well as less favorable relationships while documenting the interwoven nature of healthcare team dynamics. So as you can see here, there are some lightning bolts that are used to indicate potential issues within those between the interactions with those different roles. And on the right, you can see the affinity model. This was used to organize notes from the interpretation sessions to identify common themes. It served as a key tool to define all the significant breakdowns that were revealed during the first and second step of this process. And it also helped us to visualize the scope, the nature, and the interconnectedness of the problem. So as you can see here at the top in gray, these are the themes that were identified, and these were further broken down into sub-themes, and the breakdowns were listed under each. The data gathered from immersive experiences and through modeling revealed several common thematic elements, such as breakdowns pertaining to roles and responsibilities, coordination of care, the culture of the organization, and obviously technological constraints. The final affinity visuals are confidential, hence they're not shared here, but I will be talking about some key findings. The focus of my project was to identify significant barriers related to the use of electronic health records, which were three: inbox management, medication order entry, and inconsistent inpatient and outpatient displays in the EHR. I'll be going over each of these findings and their implication and proposing a solution for each. So for the first one, in terms of inbox management, providers often communicate about clinical cases with other staff using Epic's inbox or messaging feature, but the current interface does not provide any feedback to the sender regarding the status of the transmitted message. So providers are unaware if their message was received or read. And sometimes these communications have important case-related information that are, and the information is necessary to carry out the therapeutic plan that has been outlined for the patient. So this causes unnecessary stress because providers then have to resort to other modes of communication, often adding time to an already full workday, and also causes more frustration. This issue can be easily circumvented by incorporating a status report when a message has been sent using the built-in inbox. This status report could be in the form of a simple sentence or in the form of icons easily understood by the user. In addition, when the user is searching for the recipient to send the message to, it would be helpful to indicate if the recipient was an active user of the inbox functionality. Um, these features might serve as elementary starting points with future modifications, including more complex solutions with configuring the message filtering capabilities or creation of a team pool to enable work redistribution and triage of messages. The next important finding was a very common issue with the medication order entry process. The extensive list of medication information cannot be synthesized in one screen. That makes the selection process rather cumbersome, time consuming, and conducive for errors in selection or dosing. It often required the providers to make multiple clicks to be able to select the drug and formulation of choice. And even after all that effort, most often providers had to just call the pharmacist to enter medication orders, since the pharmacist's interface allowed them to view the medications available in the hospital formulary in contrast to the provider's view in Epic. This calls for a need to establish formulary decision support systems within EHRs. This has already been done at other facilities in more than one way. So, an e prescribing system utilizing color coding was used in a hospital in Massachusetts. The color was used to distinguish between medications as they showed up in a search result, with each color denoting preferred formulary and non formulary drugs, as well as medications that required prior authorizations. This was found to not only support providers in selecting the right drug, but also helped with generating huge financial savings. Another hospital in Kansas City developed a mnemonic for neonatal intensive care formulary, ICN. So this ICN was a code that they developed, and that stands for Intensive Care Nursery. Each drug name was preceded by this abbreviation, as you can see here. So when a pharmacist typed in ICN at the order entry prompt, only the formulary for the NICU was displayed. This made drug selection easier and also minimized medication errors. So, to overcome the differing formulary views between pharmacists and providers on the EHR, this abbreviation could be easily shared with providers to allow a smoother medication order entry process and minimize frustration, duplication, and errors. The third constraint identified is difference in EHR display depending on which setting it was accessed from. The EHR is built with some functional differences based on the setting, so inpatient versus outpatient. While this may appear to be beneficial because the tasks required would be different depending on the setting, it does cause some confusion among providers who are used to a specific display in the outpatient setting and then suddenly have to switch to a different one in the inpatient setting. And I should mention here that most of these providers do switch from one setting to the other depending on their schedule. They might be doing 1 week inpatient and the rest of the weeks they could be outpatient or vice versa. So, for instance, if a provider may be aware of the steps involved in placing an order for a pap smear in the outpatient setting, but because of the difference in the display and the available features, they may not be able to carry out the same task in the inpatient setting. So that obviously causes confusion, frustration, and unnecessary stress. So, a preliminary solution to minimize confusion when providers transition is to just provide a guidance document of some sort. So, this document would consist of simple, easy to understand instructions on carrying out the most common tasks, such as customizing toolbars, display screens, putting in admission orders, releasing or modifying orders, or a list of smart phrases to make note entry more efficient. And we have often heard that Epic, because it is highly it is definitely a more efficient platform compared to other electronic health records, but because of its complexity, it can lead to a lot of confusion about how to customize it. So, a manual like that would definitely go a long way. So here is an example of an EPIC guide that was created by the University of Maryland Medical Center, Medical System, as an example. And as you can see, this handout is quite informational with legible screen grabs and clear instructions. This would be a handy resource and must be made accessible to providers at all times. This study definitely served as a vital tool in my experiential education. It allowed me to build on the theoretical concepts that I learned about through my coursework at CHIP, particularly in systems analysis and user interface design. It provided me with an opportunity to apply contextual design methodologies at a larger scale. During my systems analysis class, we did have a contextual inquiry project that was conducted on a much smaller scale, but this allowed me to see firsthand the essential role of human factors and user design principles that went into developing uh, workplace systems and digital systems that can be used in a fast paced and heavy workload environment such as healthcare. Perhaps even more importantly, it allowed me to hone my professional skills, especially my interpersonal communication skills, and I was able to learn how to tell a story in a compelling and illustrative manner. There were some limitations in the study. We were only able to perform a small number of shadowing experiences due to a variety of reasons. Also, these shadowing experiences were of short duration, just being 1 or 2 days in general per provider. And since the recommendations were out of scope of the well-being program, they could not be evaluated. Also, the contextual inquiry approach can be considered as a subjective analysis because it does depend on the person shadowing to be able to identify certain bottlenecks, and that may depend on the person's experience or knowledge about the field of the user. Also, since the researcher is actually present in the user's natural environment, there is definitely a risk of potential bias. So, in conclusion, the modified contextual inquiry approach was definitely effective in revealing certain bottlenecks that hindered the efficient use of electronic health records. But there is more to be done. This is just the beginning. I would suggest a pilot exploratory evaluation integrating one or more of these proposed recommendations to see if they have any effect on reducing stress and burden in physicians and advanced practice providers. Also, these recommendations were meant to be preliminary, elementary starting points, and definitely more complex solutions can be uh, developed after based on the results of this pilot evaluation. And lastly, improving physician well-being is definitely an essential focus in the current healthcare climate. We read about the frontline workers every day and what they are going through on a regular basis. And I'm sure it touches all of our hearts, and it's more critical than ever before to focus on physician well being, starting with systemic and technological causes. And I would like to thank Dr. Sarah Stokes for her immense guidance and mentorship. She's been a gem of a person to work with, and I could not be more grateful. And obviously, I would like to thank my teammates, Dr. Adappa, and my advisor, Dr. Kerat, for their support as well. Thank you so much for this opportunity and for making it a fun learning experience. And now I would like to open it to any questions. Thank you.